Facilitating our next session is an anaesthetist from Monash Medical Centre in Melbourne. I could mention Nick Chrimes' many formidable achievements, including inventing the vortex approach, founding the Project for Universal Management, which is an airway collaboration with pretty much every airway expert who's ever written a chapter or published a guideline. Leader author of the Prevention of Unrecognised Esophageal Intubation Guideline, which we'll be referring to in this next session. But I know he would much rather just be introduced as a perennial and effective disruptor. Nick will be helping you to understand how, if you believe unrecognised esophageal intubation doesn't happen to you, you are the ticking time bomb that could go off next. I'll be fumbling around behind Nick, trying to put out his fires, and as usual, struggling to keep up.
So we're going to be talking about preventing unrecognised esophageal intubation. These are the disclosures first. Adam's mentioned the vortex. I don't think I have any relevant financial disclosures. Both Adam and I are directors of a healthcare education company that essentially does nothing to date. So these are the guidelines which were published about a year ago. If you haven't seen them, probably the most single important message I want you to take away from this is to scan the QR code, download the guidelines and read them. We can't really do them justice in this session. We will touch on some of the key points of the guidelines, but the intention of this session is not to rigorously go through the recommendations of the guideline. And really, if you just take away the points that come out of this session and don't go and read that have a deeper understanding from the reading of the guidelines, you will do your patients a disservice. What Adam and I are going to do in this session is really address I think the major challenge of this is getting people to realise they need to read the guidelines. So I imagine that there are a number of people in this room who, whilst they acknowledge esophageal intubation is important and unrecognised esophageal intubation is important and we need to do everything we can to reduce its occurrence, also think, but do we really need another fucking guideline? And the answer is yes. But what I want to do, hopefully, in this session is to get you to realise why we might need another guideline. And this is a more complex issue than you might realise. It's very easy to think this is something, and I imagine there are a few people with this perspective too, that yes, some people might need a guideline, but I don't. And for those people, I know you're out there, I just point out to you that the idea that anytime that you think you are above what everyone else needs, that's a red flag that at some point you are at risk of having the opportunity to become the most dangerous person in the room. What we want you to do is realise that this is a very complex situation. It's very easy to write off the cases you see of unrecognised esophageal intubation, just think, I would never do that. These are crazy people. But when you look at the cases, these are often very experienced people. They're often not difficult airways. Incidence-wise, it's about 1 in a million in anaesthesia. The best data we have on this is from NAP4, about 1 in a million cases, which doesn't sound like a lot, but when you think of the volume of anaesthetic cases that are done, the absolute numbers add up. And there are regularly, globally, cases in the news that we pick up. And probably the ones we know about are the tip of the iceberg. That increases to about 1 in 10,000 in emergency medicine in NAP4 as well. Now, it's important to realise that in the UK, most ED intubations are done by anaesthetists. So that is not a clinician difference. That's a context difference that's causing that increased risk. So hopefully we'll get you to realise some of the issues that lead to this and hopefully recognise, get a bit of humility and realise why you actually, in fact, may be vulnerable and why a structured approach to this is actually warranted. These guidelines have been endorsed by an enormous number of organisations, including the Tripartite Airway SIG, of which Linda is the chair, and endorsed by supported by those bottom organisations, but endorsed by all the major airway societies. This is really an unprecedented level of support for an airway guideline. What I'm going to do is, and I really want this to be a sort of interactive session where I actually want you to go me. If you think I'm wrong, go me, because I've found that's the only way for you to make you realise that I'm actually right. go through a hypothetical case, and I want you to do me two favours. One, I want you to approach this as if this were not a session on preventing unrecognised esophageal intubation. Try to react like you really would. And the second thing is, just for the beginning of this, I want you to answer these, what you would do here, independently. I don't want you to voice your reasons. I don't want you to talk to the person next to you. I just want you to say what you would do honestly in that situation. And then we'll get into later in the session into discussing why. So the case is this, and you can apply it to sort of the context you work in. For most people in the hospital, it could be a MET call or a code blue call. For pre-hospital people, it could just be a patient you've been called out to see. For the airway assistants, particularly anaesthetists, I want you to manage, because I want you to manage you sort of outside your normal environment. So imagine that you've been assigned to a MET team or something where you have to go out and see this patient who's collapsed on the ward or in the community. And when you arrive, they're making some respiratory efforts, but they've got some paradoxical chest movement. There's evidence of airway obstruction. Their SATs are 88. Sinus rhythm, strong pulse, good blood pressure, no hemodynamic compromise. Sternal rub, nothing, just unresponsive. So you provide a bit of airway support with a face mask. You ventilate them with 100% oxygen in a self-inflating bag. SATs come up to 100%. And you spend the next 5 or 10 minutes trying to look for reversible causes of their decreased conscious state. You don't find anything that you can change, but you uncover their histories. They're actually admitted with a infective exacerbation of quite brittle asthma, and they've got multiple allergies and documented as anaphylaxis. The team around you are getting intubation equipment ready. You've only got a direct laryngoscope available to you at that time, and you decide to do a cold look with the direct laryngoscope and this view. And you are absolutely certain that you see the tube. But when you ventilate, this is the CO2 trace you get. It just persists for as many breaths as you give. You have little blips, 5 millimeters of mercury. Now, at this point, I'm going to ask you to all stand up. And you can sit down when you take the tube out. And I know it's a nuisance getting you all to stand up, but when I've done this previously, who's pulling the tube out, who's leading the tube in, and then 90% of people don't answer. So now, if you don't answer, you have to stand up for the whole session. Okay, so they're your other obs. That's your CO2 trace. You do a quick scan of whatever you would normally do in, let's say the next 10, 15 seconds, and you can't identify obvious and immediately remediable cause that gives you back an acceptable normal CO2 trace. Just on that CO2 trace, without gathering any more information, sit down if you now want to pull out the tube. Of those still standing, how many of you are not anaesthetists? All right, about half. Okay. Okay, so what do you want to do, the remaining people standing? I'll just point out that I've done this at a couple of ANSCA meetings, and 80% of the room stays up. So that's great, or is it? So what do you want to do instead? Someone who's still standing up, you've left the tube in. What is it you want to examine before you commit to pulling the tube? Auscultate the chest. Yep. Check the circuit. Is the chest going up and down? Press the chest. Yeah. So you're going to try and do it. So trying to get some expiration. So you're thinking gas trapping. Okay. So you're going to check you've got a pulse? Okay, we have got a pulse because I actually did give you that before. Just to be fair, I covered that. So you've got a pulse, you've got a good blood pressure, and that has, but it's good to reconfirm that hasn't changed. So here are some things you could do. Who wants to look for tube misting? Oh, a couple. You've pulled the tube out and now you want to look for tube misting. too much multiverse for you. Chest rise and fall, someone said. Auscultation, we've said. So I'm going to tell you there is tube misting. The chest is rising and falling. And when you listen to the chest, you hear air entry and no gurgling. And there's also some coarse noise that might be a wheeze. It's not like an accordion wheeze, but it's a sort of just a monophonic coarse noise. Sit down if you want to pull out the tube yet. Oh, we haven't done the laryngoscopy? No, same. She's at. Well, you've caused a landslide. Okay. So SATs are still 100. So this is a good point. So I assume, Vic, what you're saying is that there's little danger while the SATs are 100. Okay, so what? Go on, expand. Yep. Did you want to catch audio because it won't go on the Teams?
Yeah, I mean, we recognise there is a.
I think that's
Okay.
all right.
Yeah,
Okay.
sure. We recognise there's a significant delay between unrecognised esophageal intubation and hypoxia, but it is at least at 100 now, and that's something. So we've got enough time to at least have a look, because particularly if this is anaphylaxis, if we've got a tube in, taking it out is going to have a downside.
Okay, we'll come back to that. This is the dangerous corner of the room, I say. Is there any other? So there's pulse oximeter lag, which is, even in a well person, is about 45 seconds between what the SATs say and when the central circulation is getting deoxygenated blood. Any other danger to just waiting and making sure the SATs drop if you think aspiration, the airway's not protected at that stage, but often we would do it. In this case, this patient was lying there for a while before we got there with an unprotected airway, so that horse is probably bolted. But we are if the tube's in the stomach, we're potentially increasing the aspiration risk by blowing up the stomach. But we're also at risk if we spend a long time doing this and just thinking, well, the SATs are all right, I've got time, pumping litres and litres of gas into the stomach. So there is a harm from just persisting with ventilation. Repeat laryngoscopy. Before we get to that, and I should have asked this question before I made people sit down, do those clinical findings on top of that CO2 trace make you think that esophageal intubation is more or less like just the trace? But you didn't sit down until you got the findings, just. Yeah. Okay, that's your repeat laryngoscopy. So this is the collective information you've got at this point. Blood pressure is good. SATs are still good. Still got this pissy CO2 trace. Tube is misting. Chest rise and fall. Bilateral breath sounds in this coarse squeeze. And that's your repeat laryngoscopy. Who wants to pull the tube out? John, you're already sitting down. You pulled it out a while back, but everyone's out now? No, last woman standing. Okay, that's the best view you can get. Okay. I respect you for staying up when everyone didn't. Impressive. Okay. Okay, so let's say that it's now we've been mucking around and listening to chests and checking for misting. Let's say it's been 10 minutes since we intubated. The SATs have drifted down a bit to 93, but they've stayed there over that 10 minutes. It's stayed at 93. Hemodynamically still fine, still a funny CO2 trace. Those of you who are assistants notice that the patient's making some respiratory effort, might be fighting the ventilation. Anything anyone wants to do at this point? That is a good point that you all pull out the tube. Put a tea bag on and see if that moves the tube. Okay, so well, you would see the reservoir bag maybe going up and down, but let's say you do that and you don't see that. That's a good trick. Anyone going to give some muscle relaxant now? Say the tube was still in. Say you arrived at this point. You haven't all been there, speaking of multiverse. You come in now and this is where you are, and you arrive to help someone who says, look, this is it. We've been standing here for 10 minutes since I intubated them. They're maintaining their stat. I'm not really sure about that.
Just to clarify the clinical situation, this patient was just intubated on spec in the ward as a collapsed patient with no muscle relaxant.
Correct.
Cool. Then no.
No, what? So,
no,
so,
I'm
so
not,
tell,
because
tell
I
us what's
don't
going,
believe.
Tell us what's going through your head.
That's not in.
It's not in. But why did you want to clarify that?
Because you're saying, should we give some more muscle relaxant? The only thing that's keeping this patient alive is their own respiratory effort.
Correct. So if you give them muscle relaxant, what you get is this. So there are cases like this, and you can imagine that the people who have gotten to this point and still think the tube is in the right place, because what we've taken out in this discussion is our own personal investment in thinking, I put that tube, I know it's in the right place. And that's a significant bias in a clinical.
This might not be obvious to everyone else, but we're in an esophageal intubation session and we're all thinking about this tube being in the esophagus. But I think most teams by this point would be thinking they're treating acute severe asthma with a very poor end tidal CO2 trace because of that. What are your comments on that? That actually, I think we'd have all lost focus on the tube by now and we'd all be thinking about treating asthma.
I think that's true. And I think, let me just show you just a little diagram that illustrates the common process that goes on with these cases. If you look at the real life cases of unrecognised esophageal intubation, there are some common themes through all of them. So if you want to look at cases on the Universal Airway website, we've put in a narrative form of all the cases from around the world that we could get hold of. There's no doubt these are the tip of the iceberg, but they're quite confronting, and you will notice some recurring themes. And what we often see is this. At intubation, there is something about the intubation that convinces the operator that the tube is in the right place. They have a belief for whatever reason the tube is in the right place. And that might be experience, or they really saw it go in and it's moved, or whatever. But it's that's usually where things start. Then there's an issue with capnography. It's not available, it's not working, there's some sort of delay, or it's misinterpreted. There's cases where it's been confused with the pressure waveform. And so to resolve this disconnect between what I thought I did and what the capnography seems to be showing me, we turn to clinical examination. And what people do is they give clinical examination the same weight as the capnography. And they say, oh, I've got misting, I've got chest rise, I've got breath sounds, and I don't have capnography. So that's three things for the tube. Three things support what I think already. So confirmation bias kicks in. And one thing I'm going to ignore because it doesn't really fit with what I think I'm going on. So I will find, so if you look at these cases, when they listen to the lungs, breath sounds are heard in 100% of cases. That's a bit of a biased number because that's why these patients died, because they heard breath sounds, so they let them in. But, in a significant number of cases, patients are dying because they get breath sounds despite the tube being in the esophagus. What they usually do is now go to an alternative diagnosis, and I think this is what John is getting at, is that once you've started to drift, and we are very much focused on esophageal intubation because of the nature of the session, but once you start to drift into an alternative diagnosis, you then say, oh, this is due to bronchospasm, this is due to cardiac arrest. At some point during all this, because the patient's not being oxygenated, they arrest. And it is sometimes, as we did in this hypothetical, it is because in that situation, they give muscle relaxant, and a patient who was fine for 10 minutes before, but had a bit of a funny CO2 trace because of bronchospasm, now arrested when we gave them muscle relaxant, and they have a history of asthma and allergy. And so, as John is saying, suddenly you tunnel down. And by that point, now you're managing a cardiac arrest and you are lost. And there is really no way for that team to find their way back other than what is usually the case, someone new comes into the room. So a crisis develops, hypoxic brain injury ensues. There is no case we could identify where a repeat laryngoscopy by the original intubator was the way that esophageal intubation was identified. But a repeat laryngoscopy by another intubator is frequently the way it's identified. Any thoughts on why that might be? Yep.
The 99% of cases that don't get reported to you or written up are when, like, if you pull or don't pull a tube or look again and then you change the tube and the patient survives and the case goes on.
No, so it's not that. So these are cases that all die, but in them where there'll be patients where the original intubator has a look and said, no, definitely in the trachea. And then later someone else comes along and says, no, that's in the esophagus.
Yeah, but I would posit that there are a larger number of cases that
Certainly.
are outside of this that
Certainly,
people would
but
check in.
what I'm asking is within that group, why is another person seeing it and the first person's not? What you're saying is definitely true, but there are a whole lot of cases we're not seeing because they didn't die. So to take a less judgy view, okay, I'm just gonna just ask, what did everyone think of our initial laryngoscopy? Yeah, hang on, let me.
Yeah, I think due to confirmational bias, like people are looking for evidence to support their theory that the tube is in. So they're looking for positive reasons to reinforce the premise that they have that they've got the tube in the right spot.
So whatever fooled them the first time fools them again. They're invested in seeing that, so they want to see that. And maybe also the other part of it is, which is a bit misleading, is that there's not many cases where the original intubator does do a repeat laryngoscopy. So there's also an element of either they're caught up managing stuff or they're just so cocky that it's not in the right place. There's one extraordinary case in the States where an anaesthetist has an out-and-out fight with an emergency physician and just says, I am not doing a repeat laryngoscopy. Patient's dead, tube was in the esophagus. That's the same patient, but with a video giving a bit of a wider view. This is a phenomenon known as glottic impersonation. Now, I will make the assumption that all of you who remained standing up despite the dodgy trace did not recognise that. So to come to their crap at laryngoscopy, I've fallen for this myself. Seeing is not believing. It is, and I think this is probably an under-recognised phenomenon, and why so many people say I'm absolutely sure I got in. And it's just the traction on the esophagus is blanching the sides of it and making it look very much like a larynx. If you are paying attention, and this comes back to what they were saying in the previous session about, I think, the deliberate process of laryngoscopy rather than just rolling with it, oh, there's a couple of white lines, I'll stick it between. It's clearly not a larynx. The cords are going the wrong way, there's no arytenoids, but you can see why people fall into it. So yes, there's an element of misinterpreting what you're seeing at laryngoscopy, but I don't know that it necessarily always falls to being just people. Sorry, I saw a hand up somewhere during all of that. Or not. Yeah, go on.
I mean, I would say this, but I can't see anywhere, and maybe it is recorded, but did anyone else other than the laryngoscopist say, excuse me, I think we should pull the tube out, or excuse me, I think I'm in the right place? So to answer your question, I would also wonder that the laryngoscopist who saw their original tube is in the right place, there may be an association with a team that doesn't work together, who isn't used to speaking up, who don't share an idea about we can all decide to confirm or otherwise what's happening here. Because probably the biggest antidote to that person having their confirmation bias is someone else saying, excuse me, I'm not sure.
And there's another benefit of video laryngoscopy.
Yeah, you can really see the ties with our previous presentations around the culture of shared decision making and empowering people to speak up, which we heard of first. The benefits of a tool that allows the whole room to understand or have some buy-in to what's going on to this point here. And this is a guideline that's not saying you as an individual need to get better. It's a guideline that's just designed to empower teams to get better.
So it's very much an interaction between, there are clearly technical things that need to be done here, but there is a huge teamwork component to this. And one of the recommendations in the guideline is for us to more formally have an interaction between operator and assistant to confirm that we are seeing CO2, which comes to the issue of what is an adequate CO2 trace. So the guideline defines this concept of sustained exhaled CO2, because one of the problems is, if we look at this trace, I assume no one thinks this is an adequate CO2 trace. Yep. One of the problems with these traditional rhyming aphorisms for managing potential esophageal intubation, when in doubt, pull it out. But I saw it go in. I don't have any doubt. No trace, wrong place. But I have a trace. And so is the corollary of that true? Does some trace mean right place? Does not. So what we did in the guidelines was to define the criteria for what we've called sustained exhaled carbon dioxide. And the aim of this is to create a clear, objective threshold that empowers the clinician to say, now we must exclude esophageal intubation. Because I think another human factors barrier into this is that no one wants to be the person who overreacts. Oh, I don't think it's that. He's panicking again. It's clearly not that. This just says game over. We're not saying it is. We're saying an unacceptable risk threshold has been exceeded, and now we're obliged to exclude. So firstly, it's the waveform has to change with respiration. There's got to be a consistent or increasing amplitude over at least 7 breaths. The peak amplitude has to be 7.5 millimeters of mercury above the baseline. And the reading has to be clinically appropriate. And by that I mean, if you've got a CO2 trace with a peak of 15 millimeters of mercury in an otherwise well patient who's got a clear chest and normal blood pressure, and there's no other explanation for it, that's still not sustained exhaled CO2, because that is not right and something weird is going on. It's very, very unlikely to be esophageal intubation. But the point here is to, as I said, exclude the possibility. And I think, why do people are so reluctant to just pull the tube? Vic touched on one thing, is that there may be dangers associated with pulling the tube out.
Like we've always been taught, if you bag mask ventilation saves lives. You know, instrumenting the airway, you are then maybe entering the vortex or exiting the cave.
Thank you for saying vortex.
But yeah, look, I think there is a fear of appropriate bag mask ventilation and skills in that. Securing the airway, we've done it, tick. And therefore you can then move down your treatment paradigm to resuscitate this patient. But I think we forget that appropriate bag mask ventilation, 100% oxygen, good PEEP, will save the life as you prepare for that next step, you know?
So there's a potential fear that bag mask ventilation might fail. There's other dangers.
Just to clarify, are you saying we kind of are overvaluing the importance of intubation and we're scared to go back? Like we've achieved this and going back is putting the patient at more risk.
I think you're making the same point we make about can't intubate, can't oxygenate, is we get obsessed with getting the device in rather than just getting gas into the patient.
McCartney, you've used enough of the room air already.
No, but he's upgrading. He wants the microphone this time.
I know, I'm on the mic. I think the thing that is never mentioned enough in these scenarios is, as very clever, high-achieving people who are told throughout our lives we're very, very clever and we're high-achieving, we're really good at what we do, we fear being wrong. And I think that is a thing that really stops people. They just don't want to admit that they've made a mistake.
Yep. So I think this is really, really important, and I think it does. People don't want to pull the tube out because they don't want to be wrong. The same way they don't want to make the call of we need to do neck rescue or the call of malignant hypothermia in case everyone says, oh, you panicked. It wasn't that. The point of pulling the tube out you're not, as I said, you're not pulling it out because you think it's in the esophagus. You're pulling it out because there's an unacceptable risk. Let me make an analogy. When we take someone's license away for drink driving, I know it's 0.05 in New South Wales, we don't take it away because we think they're definitely going to have a car accident, or even they're probably going to have a car accident. We know most people who are driving over 0.05 won't have an accident, but an unacceptable risk threshold has been exceeded. And that's what we're doing. And I think the most common thing I hear is people saying, oh, but I had this case where insert other cause of absent sustained exhaled CO2, of which there are many. Therefore, pulling the tube out would have been wrong. And I think those people have missed the point. The pulling out the tube is a precautionary measure. And the nature of precautionary measures is that they will usually be done unnecessarily. That doesn't mean it was the wrong management. And so our whole mindset change is required to say, stop worrying about whether you're right or wrong. It's about whether this is the safe thing to do, not about being right.
Nick, another important sort of example of that is where we take the time, we've assessed an airway as being difficult, we've taken the time to topicalise the patient, doing an awake intubation, then we have a look with a laryngoscope and it's a grade 1 afterwards, go, oh, what a waste, I didn't need to do that. And that is completely the wrong way to look at it. With the a priori knowledge that we have, that was the right thing to do. We had no idea what the end result was.
Yeah.
What's the reason behind selecting 7.5 as a number for a good CO2 trace? Because the reason I'm asking this is because there's enough evidence that in case of cardiac arrest, that CO2 of less than 10 consistently, say for 20 minutes, it has got a poor outcome. Or return of spontaneous circulation is almost negligible. So 7.5, I'm a bit worried. Why did you choose that?
So that's talking about different things. So that poor outcome with a low CO2 in cardiac arrest is about the amount of cardiac output you're getting. We went through the literature, which is admittedly limited, and there were no cases where if the CO2 was consistently above 7.5, that the tube was in the esophagus. Just didn't happen. Also, but adding to the safety of that is that those patients are going to have a poor outcome anyway. So, it's very hard to do any harm to them. So the point you're making is relevant for a different reason. Pulling that tube out in that patient who has that low CO2 is unlikely. People say, I don't want to interrupt CPR. Compared to the risk that low CO2 is from intubating the esophagus, which will kill the patient. If the tube's in the trachea and that's all you're getting with CPR, which is very, very unlikely with good CPR, that patient is not going to do well regardless. So it just lowers your threshold for looking at the tube. I want to quickly move on to clinical examination. This was, to our enormous surprise, the most controversial part of the guideline. Twitter went fucking mad about this. That led us to do a second paper that was led by Jan Hansel. And what we did was take all the evidence that we had looked at for the guideline and did a formal systematic review and meta-analysis. So misting, how often do you think that when the tube's in the esophagus, what percentage of tubes in the esophagus do you think show misting? 100%. I would have thought that too. I don't know why anyone got the idea that the gas in the stomach wouldn't be humid. It just doesn't make sense. The answer is 70%. So 70% of esophageal intubation. So most of them. So if I can ask you to do nothing else different on Monday when you go back to work, if your registrars, as mine do, routinely say, pass the tube, 21 at the lips, tube's misting, stop them saying that. I'm not saying stop looking for misting. If there's no misting, the tube's very likely to be in the wrong spot. But if there is misting, it effectively means nothing. So declaring we have misting is essentially saying, I have no further useful information at the moment. But saying it in a way that implies that you do, because it's starting to add up as one of these things that you are falsely weighting to be equivalent in value to the CO2, so that when you have misting and chest rise and breath sounds, the CO2 is the one that's one of these things is not like the other. Someone's hand was up.
A few slides. I just wanted to get your opinions on AMAX 4 and this case in specifics, because it looks like the first two slides, you'd be treating it as if that was the case, that bronchospastic, hypoxic arrest or collapse. And therefore, you'd be very aggressive, as per AMAX 4, about securing the tube. So actually pull the tube and then you go straight to front of neck. That would be AMAX 4.
Can I not get into AMAX 4?
Okay.
Mainly because I'm not that familiar with it. I don't know if you know AMAX 4. So this is this approach to anaphylaxis that is very aggressive about if you can't get the tube in quickly, you go straight to front of neck. I think it involves a whole lot of other issues. The thing I want to get to here, regardless of the consequences for that, is that, anaphylaxis as a cause of no CO2. What you see in the cases where they've, as I said, cardiac arrest and anaphylaxis are the main things, or bronchospasm are the main alternative diagnoses that people use to legitimise leaving the tube in. And what they often do on top of that is say, and to reassure myself, I can hear good breath sounds. So that tells me the tube's in the right place. What's the problem with this picture? I think that bronchospasm is the reason we've got no CO2, and I can hear good breath sounds. Why is there no CO2 in bronchospasm? Because you're not fucking ventilating. So, and it's just part of a disconnect that under stress, people don't realize that incongruence of what's going on. So I think that's really important, is that if you're hearing good air entry and getting no CO2, bronchospasm is not your problem, because you shouldn't be hearing anything if you've got so little air entry that you can't get CO2 back. I've done that. Auscultation. What percentage of tubes do you think that are in the esophagus that you can hear anything up to 5-point auscultation? Axillary, front of chest, no, gurgling. I said 100% in the cases. In the studies, what do you reckon? How often do you think? Sorry? 90? It's only about 20. But it's too much. If the tube's in the esophagus and you rely on auscultation to overrule capnography, you will kill 1 in 20 patients, or 1 in 5 patients. That's the inherent discriminatory value of the test. So that's often they've done studies where they put a tube in the esophagus, tube in the trachea. They have people coming in, presumably knowing the point of the study, who aren't invested in where the tube is, who have no time pressure, who aren't anxious, in a quiet room where there's no panic going on.
Sign me up for that study.
And ask them just to say, can you hear breath sounds? So you've taken out a lot of the real things. So if you add in clinician interpretation, this is a recent study in the last couple of months from the Indian Journal of Anaesthesia. They did a prospective observational study of around 100 tubes and had a staggering 8% esophageal intubation rate. It suggests they've got other problems, but 70%, and they assessed them all with capnography, ultrasound, and auscultation. And 70% of the esophageal tubes were identified as tracheal. So in the real world, the performance is much worse than that theoretical. And then, as we said, in the actual cases, it's all. So people often say, but I wouldn't use them in isolation. I would use integrated use. I would use them in an integrated way. And they often throw Bayesian in. I would use Bayesian reasoning. Here's my experience of people who use the word Bayesian. They're wankers, and that is the only thing they know about statistics. And sometimes they don't even know that. So again, Tim Cook and Jan Hansel did another study to just volley at the Bayesian thing. It doesn't work. This really so it showed that if you use Bayesian reasoning with these things, you are more likely to leave an esophageal tube in place. But to me, who's not a stats guy, I don't understand how you can take something like misting that's present in 70% of cases and add it to something like auscultation that's present in 1 in 5 cases and expect it to improve things. We've got auscultations wrong 1 in 5 times, but I've got it in association with these things that's wrong most of the time. It just doesn't make any sense. So we're not saying don't do clinical examination. Clinical examination has lots of other values. Just don't use it to exclude esophageal intubation. It can increase your suspicion of esophageal intubation. It can tell you the tube's in the wrong position, that it's endobronchial. It can identify wheeze. People went berserk that we were banning clinical examination. We're not. We're just saying using clinical examination effectively requires the clinician to know the purpose and limitations of the test so that you can weigh up that information appropriately. That's the other most important thing to take home. To wrap up, repeat laryngoscopy, as I've said, repeat laryngoscopy can be used, again, I think doing a repeat laryngoscopy if you're suspecting esophageal intubation is a valuable thing to do. But again, I would use it to confirm esophageal intubation, not to exclude it. So if you look in the tube's clearly in the esophagus, pull it out. If you look at it and the tube is either you can't particularly tell, like we had in the one we showed you, or in the case where the tube, even if you see the tube is, to your mind, clearly in the right spot, you then need to use another, what we call valid alternative techniques. And we've identified those as being bronchoscopy, ultrasound in the hands of people who know how to use it for that purpose. And because we've also made these guidelines for low resource settings, the esophageal detector device, which I won't go into because it's of no relevance here anymore. We've talked about removing the tube. And
I think that's absolutely an important point here, though, that these guidelines are not saying that you are absolutely pulling the tube. If in doubt, pull it out. These guidelines are saying you have not excluded esophageal intubation. You must exclude esophageal intubation, and you may need to make a decision about whether pulling the tube is mandatory at this point because of falling SATs or other problems, or whether you have time to exclude it using another valid method. And that's one of the key to here. It's not this black and white, you must pull a tube. There are circumstances where you should, because you're putting the patient's life at risk. But where you have that buffer, as Vic was referring to earlier, where the SATs aren't down, get your skates on and use another method for confirming or excluding that the tube is in the esophagus.
So I'm just going to quickly, because we're running out of time, go through a couple of things. So just following on from that, the first question in this is the question of danger. You know, that pulling the tube might be dangerous. When would pulling the tube be dangerous? Really, the only reasons are if face mask or supraglottic airway are considered, as John might have been alluding to, as considered highly likely to fail. Pulling the tube if you can't ventilate another way might be dangerous. But as John pointed out, if you can face mask ventilate, as in this case we knew we could, then there really is no danger. Interestingly, well, there might be one. I'll come to that in a minute. Interestingly, whether it was a difficult or straightforward laryngoscopy is really irrelevant to whether it's dangerous to pull the tube. Because if it was difficult and you don't have CO2, that would lower my threshold for pulling the tube because it's probably in the wrong place. If it was straightforward, that would lower my threshold for pulling the tube because I know I can put it back in. It's interesting to think also that probably most of you have had abnormal CO2 traces, and as you get more and more senior, the number of times they're due to esophageal intubation is low. So you can condition to believe, no, it's always something else, and that feeds into that whole bias you have going into this. The other situation in which it might be dangerous is an extreme aspiration risk. So I don't mean any RSI, but if you've got a small bowel obstruction and stuff in there coming up into the airway and you think that if we pull this tube, all this shit's going to go down the airway, that might be legitimate. But you've got to consciously ask yourself that question. And it doesn't really matter the answer. The point is, at that point, you still have to exclude esophageal intubation because you don't have sustained exhaled CO2. The question is just how. By removing the tube, which is the fastest, simplest, and most definitive way to exclude esophageal intubation is to not have a tube, or by doing one of these other valid alternative techniques. The last thing I would just want to emphasize to finish is that when you pull the tube, if you were to pull the tube, and I often see people, registrars do this, is they'll pull the tube out, they'll hold it there, they'll look and say, no, that's definitely the trachea. they'll put it back in, and then they'll ventilate again. If you get the same waveform, having pulled the tube out and confirming it, that it's going the right place, and then you still get it when you put it back, does that increase or decrease your suspicion that esophageal intubation is the cause for the abnormal trace? I'm going to answer that since no one else. For me, if I had a problem and I check and I make absolutely sure and I still have the problem, that tells me I'm sure it's in the right place and I still have the problem. Positioning of the tube is not the problem. Compare that with the situation where you pull the tube out, ventilate with a face mask, get a square CO2 wave, and then put the tube in and get an attenuated trace. That guarantees you the problem is the tube. It might not be esophageal, it might be blocked, there might be a cuff leak, but if you don't have the patient with a problem with a face mask and you do with the tube is definitely the problem. So your situation awareness of what might be going on here is radically changed by ventilating. And that's why the guideline says it's not just about pulling the tube, pull the tube and attempt ventilation with an alternative device. And so that's the last sort of key point. We're not just pulling the tube, pull the tube and ventilate with another device and see if you get CO2. We're out of time. We're going to wrap up. Thank you very much.